Welcome back to another edition of the Hart2Heart Podcast, and my guest today is Dr. Ramsey Hijazi. He's a family doctor in Ontario. So, Dr. Hijazi, welcome to the show, brother.
Yeah, thanks so much for having me.
So, I wanted to chat with you today for various different reasons, but the main reason is because you started this union of family physicians in Ontario. So, can you just tell us maybe a little bit about that?
Yeah, sure. I started the group back in July, and it really was, created of frustration with dealing with the system as a physician, but also, dealing with the system as a patient too. As a physician on a daily basis, we see the struggles, the lack of resources we have, how strained the system is, but also, from the perspective of the patient, the fact that I have family members who have lost their doctor or friends who are looking for family doctors, and it's impossible to find them, right? And so, the system is in a huge crisis and we need to fix things. And so the frustration built to a point where things spill over and I'm like, I got to do something about this. So I figured, I'm not usually the type of person to, organize and start something like this and, take an active leadership role. But I figured, I made a promise to myself I would do the best I could and, try and change things. And so that's where it all started.
So you feel like you're forced to, like you have to do it almost out of obligation, which is, in some ways sad because it reflects poorly on the medical system, but, it also, says a lot about yourself and your character and just kind of needing to, help when, it looks like there's help needed, And I certainly wasn't going to start this podcast with a personal anecdote, but you did mention previously, about, not having access, like yourself or family members not having access to good healthcare. And just a little bit of thing about myself. So I injured my back. I do a lot of MMA, deadlifting and running, lots of things. So anyways, I injured my back one day. It was mostly from deadlifting. And I had an x-ray done, showed some degenerative disc disease, had a couple compression fractures in there, went to my NP, went to a sports medicine specialist. They did what they could, but, they couldn't provide too much there, mostly just like, naproxen, recommending physio, these kinds of things. And it took me about 8 months or more, and I had to go to Toronto where I was finally able to get an epidural injection, and I had a referral sent, into a pain center, and it was rejected. And it's like, I've seen an NP, I've seen a sports medicine doctor, I have an x-ray that shows I have degenerative disc disease, I have an x-ray that shows I have 2 compression fractures. Like, what more do you need for me to be able to get for my referral to be accepted? So, that's just my personal anecdote, and that's just what happened to me. But I can only imagine the things that happen to, your patients and other people in the medical system in Ontario.
Yeah, and unfortunately, that's not unique at all. We send referrals to all different types of specialties every day, and they get rejected for various reasons. Sometimes there is no real reason. I don't know what's going on half the time, but it's extremely frustrating. Thankfully, we have administrative staff that we can offload that work to, and they do a lot of that for us because I'm part of a family health team. So that certainly makes a huge difference. But sometimes they're sending the referrals to 10 different specialists before someone finally agrees to see them, and it's it shouldn't be our job to try and chase people down to have patients.
And we don't get paid for that either. Like we don't get paid for, putting in 10 different referrals. And, I'm just thinking of one particular case now. It's an older guy with a brutal hydrocele, like it's just growing like crazy. And I just can't get him into a urologist right now. And then I have other patients, a couple of patients with endometrial cysts. They failed with ablations in the past, and, they just want to get it cut out. And, for someone to cut that out, it's almost impossible. Like if you have an endometrial cyst and you want to cut out in Ontario, you basically almost have to wait until it bursts, and then they'll, cut it out, potentially in the emergency room. But it's pretty wild, like the things that, we can't get referrals in for, and the length of time that it takes for, the specialists to get back to us. And again, I'm not like, crapping on specialists, I'm sure they're working as hard as they can. It's just, a reflection of the system overall.
Yeah, and I do want to echo that too, is that, a lot of times it's easy for us to, I think it's human nature. When you get frustrated, you kind of, blame or you shoot the messenger, right? So, a lot of times we get these rejections from specialists and we say, it's very easy to say, oh, those specialists, right? But I think, we do have to remember that these are system issues, and family medicine is in a crisis and struggling, but really all medicine is struggling. All specialists are having a difficult time. I think, for the most part, everyone is doing the best they can. And so it's really unfortunate, and what's even more unfortunate is a lot of times these scenarios do get physicians pinned against each other, right? Like, the family doctor's, frustrated and, frustrated at the specialist, and the specialist is frustrated at the family physician. And we're all pointing fingers in the wrong direction. Really, like it's the government of Ontario for years that have, not helped the system, get to where it needs to be. And, we're all in it together. We're all colleagues and we're all working as hard as we can, but the system is just so poorly run and funded that this is where we're at.
Yeah, no, I totally agree. And on the specialist part too, like you're right. So I'm in London, Ontario, and, we have very few dermatologists in our area. We have very few urologists in our area. So like, getting these people in for appointments, I mean, if it's something that's like very serious, maybe someone will see you in 2 to 3 months, which is still, a pretty long time for a serious condition. If it's something longer, like it could be 2 or 3 years, so it's the wait times just seem to be getting worse. And I don't really know what's being done about that right now. And I think that's part of the reason why you started the Union of Family Physicians of Ontario, is because it doesn't seem like there's anything that's being done, and it seems like everything is getting worse. So like, what can we do? Like, what actions would you like the government to take in order for us to be able to deliver better patient care?
Yeah, I can definitely speak most to that as it relates to family medicine. I mean, I think some of that can be applied to all specialties, but I know from the perspective of family medicine in particular, as I started this group, I started doing some research and looking into the Ontario Medical Association has a number of documents with stats about the healthcare system and funding and how many doctors we have and things like that. And honestly, it was an eye opener. I was shocked. I couldn't believe what I was reading. So, things like we actually have more family doctors in Ontario per capita than we've ever had before. And the OMA has documents with year over year stats showing every year, how many family physicians do we have relative to the population. And so I know in family medicine in particular, the problem is not that we have a shortage of family doctors. It's actually that we have a shortage of family doctors, who are wanting to practice comprehensive family medicine. People do all kinds of other things. They'll do an extra year of training and they'll do dermatology or anesthesia. Some do cosmetics clinics, some do consulting. They work for the government. And so more and more people are being driven away from comprehensive family practice because I think the conditions are so poor. I think funding in general, OHIP has been defunded, to the point where, again, if you look at the OMA stats, OHIP pays 38% of historical rates, for you to run your practice in your office. And so it's been defunded over time. And in family medicine in particular, the paperwork is just, unsustainable. The Ontario College of Family Physicians did a study that found that family physicians are spending, 19 hours a week on paperwork. So those two things are really driving people away. If we incentivized and improved the system, those family doctors who are doing other things would be drawn into comprehensive family medicine. And in fact, we would not have a shortage at all. So I think a lot of it is funding but also improving the conditions.
That's very, very interesting. So there's a couple things to unwrap there. So first of all, I didn't know that. I had no idea that there's more family physicians per capita than there ever was before in Ontario. So, clearly that's not the issue. It's some other issues. But what you just said, I never looked at that in terms of like scientifically. I didn't look at any papers, but I've just seen, family doctors who don't work too often. It's very, very rare that you have a family doctor who works 9 to 5, 5 days a week, or who even works more than, 3.5 to 4 days a week. A lot of family doctors now, they see 10 patients a day, less than 10 patients a day. Like, I'm not sure what your thought is on like, FOs and FIGs with these, different organizations where, again, like maybe they do work for some people, but, for myself, I'm just, a fee for service doctor. So, some people may not like to hear this, but I see 30 to 50 people a day, 5 days a week. I'm pretty busy in there. I see patients all the time. And, sometimes I do have to see them quickly, but that's another thing too with, walk-ins. Some people, they want it more than one thing in a walk-in, and I totally understand that. And sometimes, I do give in when patients do have more than one request. But at the same time, like, people need to understand that the reason why we do one thing at a time in a walk-in clinic is to help the ERs. So just for example, I'm going to go into my shift that starts at 2:00. I go from 2 to 6. I guarantee you by 3:30, I'm going to have to tell the girls at the front to close the doors because there's all going to be 35-ish people registered. And I'm going to say, I can't see more than 35 people in 4 hours, and so that's the reason why. Like, if I went into that clinic and I did 2 or 3 problems at one time, I could only see 15 people. That means, 20 people are not being seen that night, and then they're going to the emergency room. So I totally understand like the frustration of people when they go into walk-ins and they, see a doctor says, what's your most pressing issue? But it is the best thing overall for the healthcare system. And I know sometimes it's difficult for people to hear that, but it's true. But yeah, just coming back again though to what you said, Ramsey, I do think that, a lot of family doctors are unfortunately moving into different areas, like whether it's, Botox, or whether it's, regenerative medicine, or, whether it's, maybe doing something on the private side, whatever it is, and they're less likely to, engage in walk-in clinics and kind of general family practice and be in the trenches, so to speak. And the reason that they're doing that is because they can probably get the same pay or equal pay for doing substantially less work and really with dealing with substantially easier patients as well. And so I don't know what we're going to have to do about that. I was actually even thinking in my head one day, like, we might have to do some kind of, like, I'm against mandates, but like, I think we have to do some kind of like mandate for physicians who are graduating from family physicians, saying that, listen, for the next 10 years, you're going to have to see at least, 100, 120 people a week for basic family medicine practice if you want to, keep your license. But, if you want to do Botox and all this other stuff on the side, it's only limited to a few days a week.
Yeah, so there's a few things you brought up there that I'd probably want to comment on. So I guess the first would be you mentioning that a lot of family doctors' offices are not open, or they're not seeing patients 5 days a week, and seeing 20, 30 patients a day. And I think that's true. That kind of adds to my point that a lot of family doctors are not doing comprehensive family medicine. So it's not an all or nothing thing. Sometimes people are doing comprehensive family medicine, but they do those side gigs to kind of supplement, their practice, because it's, they want to do family medicine, but they just need to, like you said, do stuff that is a little bit simpler and easier. It doesn't have the paperwork, burden that the other work does. So a lot of physicians do it part-time. And so it's, leads to the same point where, family medicine, comprehensive family medicine is being de-incentivized. I personally, I don't think the mandates are the way to go. I don't see how practically that could ever work. I think, even if you look at the Ontario Medical Association and the government and how they've handled the last 20, 30 years, I think the biggest problem is, they're trying to figure out all these solutions, but they're not looking at what are the underlying problems. So even when they allow pharmacists to prescribe more medications and allowing nurses to prescribe medications, I mean, it sounds great from a patient care perspective in terms of access. They have easier access, but those are just band-aids. And I think by the same token, mandating physicians to do this or that after they graduate is not really addressing the underlying problem. The underlying problem is that medicine has been defunded for years by OHIP to the point where it only pays 38% of historical rates. And so when you're running a small business,
Can you just explain that? Sorry, the 38% of historical rates.
Yeah, so when OHIP was first started, I believe it was sometime in the mid 60s, um, the government agreed to pay OMA rates, the Ontario Medical Association rates, for fees. Um, and then within a couple of years, the government actually said, well, actually, no, we're reducing that to 90%. So we're going to pay 90% of OMA rates. And so the OMA has since that time kept track of what the rates are. And basically what they do is they look year over year and they account for inflation, rising expenses, and they update the rates based on those factors. And so the OMA again has this document which shows year over year what the OMA rate is compared to what OHIP pays. And it's gotten down to the point where it's 38%. The OMA now uses a multiplier, so the multiplier is 2.6 for uninsured services. But the inverse of 2.6, 1 over 2.6 is 38%. So that's how I get the 38%. And so, when you're running a small business, you're running a clinic, you're paying staff, salaries, you're paying for rent, and all those costs are just booming in the last several years. And your budget has essentially been cut to 38% of your historical budget. It's a failing business, right? Like every year your expenses go up, but your revenue remains stagnant. So you're like any other business is a failing business. That business is going to go bankrupt. But physicians have just continued to kind of personally fund and subsidize the clinic. So I think if you're going to fix a problem, you need to look at what the real solutions are and address this, or what the real. If there's a situation, you need to look at what the actual problems are, and in order to fix it, you need to address the problems. So I think even things like mandates and stuff, I can't ever imagine anything like that working. And it wouldn't fix the problem either. I mean, there's always going to be people who will find ways around those kind of things as well.
So, Ramsey, in terms of the job action proposal in that article that you put out, can you just tell us a little bit about that particular article? And I think it was covered in Ottawa Citizen. Is that right?
Yeah.
So that was kind of how I discovered you and found out about you. And so, what is sort of the job action proposal, the Cliff Notes version?
Yes, we have a couple things that we want to recommend to members, and none of these are, at least most of these ideas are not completely novel. Like, in fact, these have been, happening silently for years, and physicians often, have been putting up with the system in silence, and they don't complain and they don't say much, and so I think we're recommending people be more vocal about it. And so, a couple things. So we're recommending that given that we spend on average 19 hours a week doing administrative work, which is usually done, the paperwork's usually done in the evenings and the weekends because, we're so busy during clinical hours, we don't have time to do it, during clinic, at least not a lot of it. And so one of the things we're proposing is, cutting an hour or two off your clinical hours and doing paperwork instead. And so unfortunately, that means that less patients are going to be seen in a week. But that means that you're not going to be spending the majority of 19 hours in your evenings and weekends doing unpaid paperwork. And so I think part of that is it was not a decision that was made lightly. And I think no one likes to cut clinical hours. It's certainly not ideal. But at the same time, the way things are set up are not sustainable. And I think a lot of physicians more than ever are burning out. And so part of it is to bring attention to the issue, with patients and the government, but part of it is also looking out for physician wellness. And so we're saying, instead of spending 19 hours a week on the weekend doing paperwork, maybe you'll have 17, you'll have an extra 2 hours with your family because, you'll do it during clinical hours. And in fact, so I made a decision to do that myself probably about 6 to 7 months ago, I was just spending so much time on the weekends catching up on paperwork, and I had enough of it. I was burning out. And so I cut out, 2.5 hours off one of my afternoons, and I still see patients anymore, unfortunately. That's 10 less patients a week I see. But that means that it's a little bit more sustainable for me. Um, the other things we proposed were, if you are fee for service, as you mentioned, um, for walk-ins and stuff, if you're dealing with more than one, sometimes physicians will deal with 2, 3 issues in that system, and we're saying, you know what, like the system is set up for one problem per visit, and that's what they're being funded for, and so that's what we need to stick to and be more rigid with. Obviously, if there's something urgent, that there's an exception there for sure.
Do you think though we could do 2 bills for one visit? Like, do you think that would get messy, or do you think that would be a reasonable thing to propose?
Like as a change to the system? Yeah, certainly. And actually, we do have. I know we have at least one member in our group who has been very vocal about making a change like that, because they believe that would be hugely beneficial. And I definitely don't disagree. I don't disagree.
Yeah, I think that would make a big change for family physicians, like you said, especially in the fee for service sector, like myself, because then you are more inclined to take on the second issue, but then it doesn't solve the other issue though, of like the emergency room issue with like the walk-ins, reducing the emergency room because they're only taking the most pressing issue, but it does solve the billing issue. So I think that, it should be something that we can do, but it doesn't necessarily mean something that like you have to do all the time. I still think it's a reasonable thing that like the walk-in clinic I work at is really like a 2-minute walk from the emergency. So people go there like instead of the emergency kind of thing. So, I still think seeing, one, problem per patient, if it's like, in a walk-in clinic that's supposed to deflect from the emergency, is still a reasonable thing to do. But at the same time, I think putting in that proposal would make a big difference for family docs, and probably would, offload on the income to expenses ratio.
Yeah, and I think one of the issues I've encountered, with the Ontario Union of Family Physicians is you realize very quickly that in a big group like that, everyone has an opinion and everyone has different things they want to suggest, and they're all great ideas. But I guess as a group, it's very hard to stay super focused and come up with 1 or 2 things you want to ask. And I think when you're bringing that out into the public or to the government, you need to be very your asks need to be very simple and clear, and they need to also be beneficial to members across the board, no matter how they're practicing, right? And so I certainly think that billing more than one issue per visit would be it makes sense. It's a huge it probably needs to happen, really. But the things we came up with at our group that I think we feel would be most beneficial would be, number one is to ask for overhead support. So have the government supplement our expenses for rent and staff and things like that. There is precedent for that. BC and Manitoba just came up with new contracts, and I believe it's in Manitoba they have some overhead support now. If you work in any physician who works in a hospital, essentially their staff and facilities are funded. There was also an article that came out a couple of weeks ago, I believe, where private surgical clinics, it came out that they were actually getting, I believe it was 40% bonus on their OHIP billings. And so,
wow.
Yeah, it was, I don't know why more didn't come of that, because, a lot of people are concerned and talking about the privatization of medicine, and they're concerned about this government in particular leading to privatization in medicine. And to me, that was a bombshell, so, and the way I see that is that if you're supplementing these surgical clinics, well, you're helping them pay for their clinic and their staff. Like if they were in a hospital, they wouldn't have to pay for facilities and staff, so you're giving them a bonus to cover that. And so if you work in a hospital, you have your expenses subsidized. If you work in these private surgical clinics, you have your expenses subsidized. So why are we left out of that? I think we should be a part of that. And
Yeah,
going
yeah,
into a little bit.
that's crazy. So just so I understand, so private surgical clinics in Canada, so meaning people who pay, out of pocket to the surgeon for a particular service, that surgeon will have his staff covered for by the government. Is that correct?
Well, no. So I'd have to look at the article again. But what I believe
Okay.
it was private surgical clinics. So it's OHIP covered surgeries,
Okay.
but it's just done in private facilities.
Okay. Okay.
So
I understand. I
it's
understand what
not
you're saying.
private surgeries paying out of pocket. It is OHIP covered surgery. So OHIP is paying for the procedure, but rather than just having the typical OHIP billing, they're also giving, a top up on top of the OHIP billing. Um, so yeah, I think, asking for overhead support makes a lot of sense. And going into a
And so,
little
not
bit
to
more.
cut you off, but when you say overhead support, like what number do you think would be a reasonable number for them to support us on?
I think they should be covering. We put forward uh, an ask of 35% over OHIP billings. I think from the majority of family physicians, that would cover most of our, overhead expenses. And I think
So
that seems reasonable.
you mean a 35% increase in OHIP billings to cover the cost of rent and staff, or do you mean they would subsidize or they would pay 35% of the rent and staff?
No, I mean, like when you look at your OHIP billings for the month or for the year, they top up to 35%, so they're covering the majority of your. Which again, I think there is precedent for that. If you look at hospitals or private surgical clinics, and going in a bit more detail with that is we are asking for that to happen, but also that rate is adjusted based on something like a consumer price index, so that if inflation and expenses go up, that rate also goes up. Because I think one of the biggest issues with the defunding of medicine is that rates, they have gone up and they've gone down. It's not like they've consistently, in absolute numbers, gone down, but with rising expenses and inflation, that's where they've been cut to 38% of historic rates. And so the government can always, throw us a bone, but if that doesn't keep up with that, then we will start losing money again. And so we're asking for overhead support, but it being indexed to a consumer price index or something that's going to take into account these rising expenses. And that could be a permanent, um, something that would help permanently and that would keep up with, over time. And so that's one of the main asks. The second ask is, for paid administrative time. So like an hourly rate to do administrative time. I mean, there's a lot of talk about solving the admin burden and helping family physicians reduce the amount of hours you're spending on admin time. I think that's a bit of a pipe dream. I think, we can make improvements for sure. And there's sometimes little things that can make a little bit of a difference, but there's so many players involved. There's the hospital, there's there's the Ontario Health, Digital Ontario Health. There's, specialist offices. There's all this stuff that's coming in electronically is coming from so many different people. To fix the administrative burden is a huge, huge, huge task. And so that is going to take years and years. And so certainly that should be a goal, but I think that, especially with the upcoming negotiations or the ongoing negotiations with the government right now, with the next contract being due in March, I don't think a promise to fix the administrative burden is feasible or acceptable. I think what we need is to pay us for the administrative time, and then at least that way we'll still be dealing with it, but it will be a bit of a morale boost, and it may incentivize people to come over and practice comprehensive family medicine, because at least if they're going to be doing the work, they're going to be compensated for it.
Yeah, no, I think that's a reasonable thing to propose. And I think it's something that can be implementable right away. And that's, clean. Trying to get them to, like, I was just thinking in my head while you were talking, like, how would they, pay for my staff or pay for my rent? Like, what would I do? Like, send them an invoice every month for my staff or my rent. And like, that can get messy too. Like, cause they could think, okay, well, why do you need this much staff? Why do you need this much space? And, that kind of thing. But just like a plain fee over the top, 35%, I think that would absolutely do it and cover things.
And
So
then
is
it's up
that
to you,
more?
and then it's up to us to kind of manage with and work, make that work, right?
Yeah, absolutely. And in terms of, what you are proposing, like that's a pretty decent number, right? Like what I'm saying is like that would basically, from my perspective, more or less cover it off and solve the issue. But are you guys proposing anything more? Or?
We originally had a number of proposals, and I think it just got too complicated, and a lot of people, yeah, I mean, even our members, like they just would read it and they said, people are not going to get past line 3. So we really tried to get rid of some stuff that we thought were good ideas, and I think there's a lot more work that needs to be done and a lot more things that could be beneficial. But we're really trying to simplify it to those two. I think we felt those two were the most important aspects to consider. And and again, yeah, like you said, those can be quickly implemented. And I think that's the goal. Is like we're in a huge crisis. We need stuff we can implement right away and fix things immediately. If they, if they actually carried out those two asks from our group, I have no doubt that within a year or two, you're going to see a lot more people practicing family medicine. You're going to have a lot less difficulty finding a family doctor. Like those two things single-handedly could have huge impacts on fixing the family doctor crisis.
Yeah, well, I really hope that the government, listens to your proposal and accepts it. And I think that, again, that'll be better for family doctors, but more importantly, it'll be better for our patients because we'll have access to family doctors like they don't have right now. So yeah, I really support what you're doing there. I'd like to chat with you more about it after the show. Couple of the things that I did want to chat with you about today. What role do you think NPs or nurse practitioners have as a role in medicine and primary care, and how do you see them acting in primary care in the future in Ontario?
Yeah, so I mean, I do work with a number of NPs and even some PAs, physician assistants, and have for years. And I mean, I think they can be a valuable member of the team. Um, I think what the government has tried to do is they've tried to have NPs replace physicians, and now you're seeing these a lot of them are private, NP-run clinics, and I think those are really not a good idea because um, the fact of the matter is the scope of practice is not entirely the same, and unfortunately, physicians are the only ones who are held to with the labor laws. They can't do private medicine. The NPs can open private clinics. I know there was a private clinic that opened up in Ottawa, and it created a huge uproar. It was all over the news. Sylvia Jones said, "We're going to investigate into this clinic." I think they were charging $400 a year for a subscription, so that you can see the NP for the year. And they made a big fuss of it, but I don't think anything's going to come of that. I don't think they're actually doing anything wrong. I think the government's trying to make it look like they're against that, but I don't know that they are really. And so I think that when
But
you are,
and just to interject there, Ramsey, don't you think that too is also like a testament to the fact that people are frustrated and they can't find a family doctor? Like
absolutely,
they're willing to, and again, don't get me wrong, I work with nurse practitioners and sometimes I ask them clinical questions. Like, they're very, very well trained. But what I'm saying is like people are willing to go to a nurse practitioner instead of a family doctor and to pay out of pocket because they can't get access to the primary care physician. I mean, that's the real issue. Like, sure, maybe the government should look into it and see what they're doing. But if they're just, providing care for patients and they're doing a good job and the patients are happy paying out of pocket, then, more power to them. But like I said, they shouldn't have to do that. They should be able to go to a family care doctor and get proper care and not have to pay out of pocket. But unfortunately, people's hands are being forced. They're frustrated with the system. So, they are going to these NPs.
yeah, people are desperate. People are absolutely desperate for care, and so and it's funny because that nurse practitioner clinic, again, I believe was charging a $400 subscription fee. which to be frank is, almost double what physicians bill OHIP. Like I'm in a family health team. For every patient I see, on average, it's about maybe 250 for the year we get paid for a patient, and the NP clinics are charging $400. And so that's a little demoralizing, and we're stuck. Like there's nothing we can do to change our fees. But people are desperate. That clinic in Ottawa, I believe, from what I heard, had 10,000 people sign up within the first, I don't know if it was the first week. So clearly, people are super desperate. People are willing to pay out of pocket to get care, and
Yeah.
it's true, right? So
I mean, I understand. Like I said it earlier. I'm not hiding anything. Like the walk-ins that I go to, like sometimes that I work at, like sometimes you will wait 2 hours there, and there's nothing I can do about that. Like I said earlier, you're kind of damned if you do and damned if you don't in family medicine, because like if you go through patients quickly, then patients think that you're not being empathetic, you're not spending the right amount of time with them, which fair enough. Like that's true sometimes. But then if you go too slowly, then patients are like, okay, I'm waiting here all day, like no one's gonna see me, like and then they may have to go to emerge, and then emerge gets flooded. So the bottom line is that we need healthcare practitioners seeing patients, and at this point we don't have enough. We have enough healthcare practitioners and family doctors, like you said at the beginning of the show, but we just don't have enough doing comprehensive family care medicine. And it's likely because of the way that the fee structure is set up and the expenses that we have to incur, and inflation, and the fact that it's very difficult to get staff. I mean, I chatted with someone recently, a family doctor, and he said he had to put one of his staff up to like $25 an hour at the admin just to be able to keep them there. And people say, that's not that much money. I mean, if $25,000 is roughly about $50,000 a year. So if you don't know that rule, whatever you make an hour, double it and put in thousands is roughly what it is. And so that's a lot of money that you have to pay someone. And that's just one staff. So you might have to pay other staff as well. So like you said, it's the rising costs in staff that's really, burdening family medicine. You're never going to get someone to work for you for, $12 an hour or $15 an hour anymore. Like those days are gone. And I imagine, Ramsey, that you're probably seeing the same thing at your clinic. Have you guys had staffing be an issue and seen rising costs recently in recent years?
Yeah, I mean, we've had a number of staff leave because they go to either private clinics or they go to dental clinics where they can increase their rates, right? Like as inflation goes up, they can increase their rates. And so, they increase their rates so that they can pay their staff more. And we don't have that luxury. And so, we've had staff leave, and it's expensive to lose staff because then you need to go engage in a rehiring process and a retraining process. And then sometimes you go through all that, and then shortly after they're gone. And so, we've had that issue. We've also preemptively given, all our staff raises in the last year and a half when inflation was really going high. We figured, it's actually probably smarter and easier to invest in the staff now to try and keep them than it is to lose them and have to retrain. And so even that was a huge expense. And even then, we still are losing staff sometimes.
Yeah, and then it's also too, like when you lose tasks, you lose time as well. We've talked about time a lot on this podcast, and the time it takes to retrain someone and go through things, and then a new staff may not be familiar as much with the fax machine, referrals, how you do things, so you have to spend more time with them, and so that creates more and more work. And I know we only have about 10 minutes left, and so there was a couple other items here that I did want to get into. I know we've talked about this a little bit in terms of people entering medical school and that kind of thing. But why do you think that there's doctors right now who are tend to leaving family medicine just in general? Like it seems like yes, we have the issue of, we know there's less people being recruited for family medicine, but in terms of just like family doctors, like in particular around like our age and thing, like it seems like they're just leaving medicine in general. And does it just come back again to this income versus expenses that we're really facing here in family medicine? Or do you think there's other things going on? Like, do you think like the job is becoming more difficult? Do you think that patients maybe are becoming more demanding? Like, do you think that there's other reasons, particularly why doctors are leaving family medicine, besides the income to expense issue that we're experiencing?
Yeah, for sure. And I think, we've always kind of talked about the two. So the defunding and family medicine is a failing business, where our expenses are going up and our revenue is not. So that's definitely a huge one. I think the second issue we've talked a lot about is the paperwork. When you're spending 19 hours a week, that's half a full-time job you're doing paperwork, and that's usually after hours, right? So I know even for me personally, that's a huge burden, and it leads to burnout, and it's just that is a huge factor as well. You can leave and do something else, and you may be working hard, but you're not going to be spending all that time after hours doing the paperwork. But and we haven't, our group hasn't really talked about this too much, but I think you do bring out another good point about patient complexity and patient demands, and I think that certainly is a factor as well. I mean, 30 years ago, it was very paternalistic medicine. Your blood pressure is high, you need this medication, take it, see you next time, right? And there was no questions asked, and it's not like that anymore. And in a way, that's a good thing that patients are empowered and patients have more knowledge. But it certainly makes the job more difficult because, it is time consuming. So, often now you are making a recommendation and the patient has questions, and sometimes they've done their own research and they want you to review the research. And then, they challenge you, which, I think, again, if are all healthy things, but it's a huge change for all the patient, for many patients to, when that all happens kind of en masse, it adds a lot of complexity and a lot of time to your day. And so, it's not a simple visit where you're dealing with one problem and, you quickly investigate, you tell them what needs to be done, and it's done. That's the way it was done, 30, 40 years ago. It's not like that at all anymore. It's much more of a discussion, answering questions and things like that. And so, is that why doctors are leaving? I don't know, but certainly the job is harder and more complex, and you get challenged in a lot more things.
Yeah, I think you get challenged a lot more. And I think also too, patients just like expect a lot more, out of the visit. Like even if it's something for like a sore throat. I mean, if someone has a sore throat and they got pus in the back of the throat, I mean, really all you want is some antibiotics, maybe some recommendations for cough drop and, some Advil and that kind of thing. But, even if someone comes in for something as simple as that, they still want to make sure that you genuinely really care about them. And I understand that, but that still takes energy, time, and effort from you that, kind of, drains you a little bit, where you may not have as much of that energy at the end of the day. Whereas if you can just go in, look at someone's throat, say, hey, your throat looks sore. Here's some medicine. Here are a couple things that might help for symptom management. You can be on your way, which you can do in like 60 to 90 seconds. Like you can treat someone that quickly if it's just, a sore throat. You can get the history literally and, before you get into the room, if you have like a good admin staff and that kind of thing, and it can be done. But, most patients, and I do understand, they still want to be treated whole as like a person and make sure that, you really care about that particular person. And, there's that quote Mark Twain says that like no one really cares how much you know until they know how much you care. And I understand that. But again, like, when we're trying to get through patients, we are just trying to deal with the medical issue at hand. And then the other part of that too is that mental health has become, massive over the past 10 to 20 years. And I would say that, Ramsey, I think you'd probably agree with me that like 30 to 40% of your patients probably have, you've probably chatted with them at least some point about mental health. If you include insomnia in there, which sometimes gets grouped into, mental health disorders, depending on who you're talking to, it's probably north of 50%. And so these things take a lot more time. So the conditions, the complexity is there's a lot more expectation, because mental health is not something that's and it shouldn't be swept under the rug anymore. And we do have, some treatments for it now that are effective. But, people do need to understand that it's going to take a lot more time to go through, a lengthy mental health visit when someone has depression or anxiety than when they're just coming in with like a sore throat or a cough.
Yeah, for sure. And I mean, and it's, mental health and is, definitely an increasingly a problem that we have to deal with. And also it's like psychosocial stuff too. Like sometimes it's not a primary
Mhm.
mental health condition, but it's, you know, social and work stressors and things like that you're dealing with as well. And yeah, all that adds a lot of complexity. It takes a lot of time. And
Yeah, I agree. And I don't mean to interrupt you there again, but the psychosocial issue is something that, we need to address and look at, because some people, have these kind of hippie fairy tale sort of, mindsets where they're like, money doesn't matter. Like, you kind of should be, happy anyway. This sort of mindset they may say to their patients. But, psychosocial issues are very real. And, people who have, lower income, they are subjected to, just worse treatment overall, worse, outcomes in their health, obviously worse outcomes in their employment. And all this stuff does add up, and they do want to talk about that with their family physician, and they should be able to. But also too, if we're going to, take on more complex patients and do more complex care, then you should be, compensated for that. So kind of what I'm getting at here is like, unless you go over 20 minutes and you use the K code, you're basically getting the same pay for 15 to up to 19 minutes of time for a patient by, discussing, different mental health strategies, whether it's for anxiety or depression, than if you just see someone for a sore throat. And obviously, I think that pay structure should reflect very, very differently than it is now.
yeah, and that's definitely a fair point. I mean, I think there isn't a lot of complexity that's built into a lot of the the OHIP rates, and I mean certainly that would be something that could help, um, at least make us feel like I mean obviously I was going to say justified, but obviously if someone is in having a mental health concern, obviously that time is justified to spend with them. But it would be I guess validated financially so that you could. It's sustainable. I guess that's a big thing. It has to be sustainable. I mean, if that happens all the time, then you're kind of running into the same issues of costs increasing and your revenue is not. Um, but I think all this, and you mentioned this before too, like often we don't have the time and it's difficult to spend time with patients, and I think that also was a big factor in burnout too. I know that when I was a resident and I first started practicing family medicine independently, and you're seeing patients quicker and you're doing more than you would as a resident, I, I was like, I was kind of shocked. I thought, like, how do we only have 15 minutes to see the patient, write the notes, prepare any kind of referrals or investigations that need to be done? That's not a lot of time. I mean, eventually you get used to it and you learn to, safely cut corners where you can. But I think a lot of burnout, also is derived from feeling like you're not doing the best job you could and not spending the time you can with patients. I would love nothing more than to have a little bit more time with all my patients, but um, a lot of it is because there's just too much demand, right? And so if we could fix the crisis in primary care, get more family doctors, and everyone had a family doctor, and perhaps we wouldn't have to take on such a big roster of patients. Uh, instead of having a practice with let's say 1,500 patients, maybe if it was if the system was redesigned and funded properly, you could cut that down to 1,000 and still be sustainable and spend more time with patients, and it would be better for everyone, right? So I think that's a big thing to consider as well.
Yeah, I agree with you 100%. And Ramsey, unfortunately, we're running out of time here. And I know you got to get back to your patients, and I need to get back to my patients in about an hour time soon. But, before I let you go, where can people learn more about you? Where can they learn more about the Union of Family Physicians of Ontario?
Yeah, so a great place to start would be our website, which is oufp.ca. From there, we do have access to a lot of our educational materials. We have templated letters that you can send to your MPP. We also have a petition that we started online, which is at about 30,000 signatures right now, demanding the government
Wow.
for change. Yeah. So please check out the website, sign the petition. We are also on Twitter. You can also, there is a link to our Twitter account off the website too. So the website's the best place to start.
Okay. Okay. Awesome. Well, I'll definitely be sharing that with people online and signing that petition. Thank you so
Yeah,
much
thanks.
for doing that, and thank you so much for coming on the podcast, Ramsey. Really, really enjoyed chatting with you today. It's really nice to chat with another family physician in Ontario who understands the struggles of the family physician, and hopefully, lots of people hear this and take action and sign that petition, and hopefully we can, deliver better care to our patients in the future. So thank you so much again for coming on. And for everyone who listened today, thank you so much for listening. And as always, I'll be back again soon.